Well, sure. But you've got the new medical school, and then are you asking for this? I guess the question is, I'm asking, are you asking for the 150,000 square foot building for research when you could use existing space you're going to use for the med school, and are you going to be crimping these other schools and their growth by using space for the med school?
No. We do have excess capacity to support the student growth up to about 2,500 students total on our campus without the new research building. The research building is purely that, is to help support the growth in our research programs.
Well, 30 years ago, and there was kind of a bias with osteopathy versus allopaths and all that. I mean, those barriers seem to be down. I mean, there's mixed groups. Do you not have mixed DO/MD groups in the Fort Worth area? I mean,
there are. Of our 240 physician faculty, about 2 of 3 of those are MDs, and about 1 of 3 are DOs. We have DO chairs, we have MD chairs. I'm a DO, a proud DO as president. The president of the practice plan, though, is an MD. So we're a very mixed campus right now on our campus.
I went to medical school in Virginia, but I did my residency in Pennsylvania, and we actually had mixed residency classes in all the different specialties at what now is the Penn State program, and the Philadelphia College of Osteopathic Medicine is a great school. But I think, and we don't want to, Louis Grizzard said, when the Yankees come south, don't tell us how you did it up north. But it seems to me like rather than starting a whole new school, you've got such a great record with your school that time would have been better spent to talk to community leaders in hospitals and break those barriers down and not mess with such a great record of putting out primary care physicians. I think you're rocking a boat here that may not need to be rocked, and you may sink the whole ship in the process. And I think you need to really think through before you do this, and as you look at the budget this year, I'm sure budgets will be tight in the years to come. Is it really going to be worth the dollars that people have given you? Is it going to be worth state dollars to pursue? Because at some point, it's going to cost the state money to keep your allopathic school going if you indeed you get it. So I applaud you for thinking outside the box. I think there may be some flaws in your thinking at this point, but we'll continue the discussion. Thank you.
Thank you.
Appreciate you.
Well, we are very committed to primary care, and in fact, that's part of the reason we're doing this, to support even improved primary care from where we're at. We're ranked 19th in the country of all the primary care medical schools. The only DO school in the country that's higher than us is Michigan State University, that has both a DO and MD school on their campus. So we do believe there's a lot of leveraging opportunity to even become even better.
Senator Zafreen.
Thank you, Mr. Chairman. Dr. Ransom, I had a series of questions about your written testimony on page 4, reductions in faculty staff to critical levels for faculty staff ratios, scaling back academic support to critically low levels necessary for accreditation, et cetera, et cetera. But then I got involved in listening to this conversation about the medical school, and I was comparing your request or your plans for medical school, not your request but your plans, to your request for a TRB. And usually people who request TRBs make very good cases. Sometimes they're almost desperate. There are health issues and safety issues involved. And it's difficult for me to juggle the two. To hear you, or to read your testimony and to hear you talk about these critically important needs, and then hear your plans for a medical school. Either one independently would be all right, but the two combined somehow boggle my mind.
And we are working to grow all the various programs on our campus. We've grown literally all the programs on our campus across the board, and we have not reduced any faculty. We're continuing to grow faculty. Our challenge is trying to figure out how to continue to grow faculty with the budget cuts at the same rate that we need to have more students. So, for example, in the physical therapy program, that's a new program, a relatively new program. We're working with it, and we're trying to grow the number of faculty necessary to support accreditation, and we're working with the practice plan and research and others to leverage these dollars. On the research side, that is something we've grown very, very substantially, as you can see in the various charts and graphs that we have on research. The new research building is not a patient safety issue. It's all about research, and it's mostly basic science and clinical type research.
But why can't you raise money for that instead of for a medical school?
The philanthropic community, before I arrived at the Health Science Center, we had never raised more than $1 million. And I know my predecessors had tried to raise money. And fortunately, we've increased the funding from the philanthropic community, which is mostly from Fort Worth. And this past year, we raised just over $30 million. I believe this is something that has really engaged the Fort Worth community like never before. We have community support from every big organization, the chambers, the community across the board.
You've raised $25 million?
We've raised over $30 million.
$30 million, and you're saying that you have all expenses covered for the first 5 years?
Yes.
And that it wouldn't cost the state a penny for those first 5 years?
No, ma'am.
How much would it cost us in the 6th year?
It would be the normal formula rate of whatever the normal formula funding rate would be for the additional medical student.
So basically, you're telling us we don't pay now, but we'll pay later.
Well, very similar to Dr. Dickey as she was trying to grow the medical students at her campus. There was a special item to support that growth, to get it up to the formula funding, kind of the normal rate, to be able to support ongoing costs. The good news, we've raised enough money to support all the startup and all the operating costs for those 5 years to get us through this critical time of development. But then after that, we would like to request very much to support from the formula funding.
Well, I'm just having a difficult time balancing, the critical needs on one hand, and then these plans, these elaborate plans with a pay later strategy on the other hand. And so it's just difficult for me to balance the two. The other thing that bothered me a little bit about your testimony is that you portrayed as if we have this wonderful support and the community is united, but I've also heard from people who oppose it. A number of your alumni have been very, very passionate, and you didn't touch on that at all.
Yeah, looking at the support and the detractors, if you are not one of our graduates from an osteopathic physician, I think it's pretty uniform. I'm unaware of any group or group that's opposed. The Chamber of Commerce, Fort Worth, the Hispanic Chamber, the Black Chamber, all the hospitals, the big medical groups. In fact, a large medical group of 400 doctors, includes about 60 DOs, gave us $500,000 to support this new medical school. It's a big deal in Fort Worth. On the osteopathic side, 25% of our donors were osteopathic physicians, including the only living founder of TCOM, Dr. Everett. There is definitely some in the osteopathic profession that do not like this at all. I'm very aware of that. And I don't know what percentage love it and which percentage hate it, but there's definitely a group that love it and a group that don't like it. And there's probably the biggest group, honestly, is the one that doesn't really care one way or another. The group that likes it, and I think it's important to understand why. This is something that the group that likes it, including Dr. Everett, that believes this is going to do more to protect the long-term security success of TCOM than anything else. And the reason for that, with all 10 osteopathic hospitals in the state closing over the last decade and a half, we need to partner with general hospitals. And to have both the DO and the MD program, we can support everything. We can support all things for these hospitals of what they're wanting. And clearly the hospitals, at least in the Fort Worth area, that have all given a lot of money to support this. Hospitals usually are recipients of donor dollars, not givers of donor dollars. I think it sends a very loud message of how this can really help. So I'm very proud DO. I believe this is going to do more to support the success of the future of TCOM as well. It's opened the doors to the philanthropic community like never before. We had a meeting on Friday. We had 80 people talking just on the MD school. These are all people who have given money and other kinds of support for the MD school. These are the leading names of Fort Worth, without question. I think most people here would recognize most of the names anyway.
What is the racial, ethnic, and gender makeup of your student body?
Michael, did you have that right here?
I didn't see it in your testimony. Many people have included it in their testimony.
For the UNT Health Science Center as a whole in 2010, we were 17.1% underrepresented minorities, and 55.7% were women. The groups, or at least the programs we have, are very diverse. The School of Public Health actually does have the most diverse School of Public Health in the country. Actually, it's been that way for about 4 or 5 years now. The Graduate School of Biomedical Sciences, similarly, is very, very diverse. TCOM and the PA program are somewhere right in the middle of the medical schools in the state of Texas. TCOM is now 11.7% underrepresented minorities, and 48% total are women.
When you say underrepresented minorities, whom are you including?
The definition of the state of Texas for underrepresented minorities, which are Hispanic, African American, and American Indian.
Asian Americans?
No.
No. What about the ethnic, racial, and gender makeup of your top administrators?
We have 2 Hispanics.
At what level? The people who report, how many people report to you?
7.
7. Of those 7, how many are minority?
1.
Which minority?
She's half Hispanic and half African American.
So and how many are women?
2 of the 7.
2 of the 7. Okay. The other thing that bothered me is that recently we saw copies being distributed of an article by the Texas Tribune about the top salaries in higher education, and yours is the very highest, 20% higher than the UT chancellors. And it's just an amazing listing. And again, it's difficult for me to balance the critical needs that you identify in your oral and written testimony with these impressively high salaries. Either one in isolation we could handle, but the 2 at the same time are difficult to balance. And how do you justify these high salaries?
Well, the UNT system regents at the advice of the chancellor determine the salary of all of our presidents. I know they do it based on market benchmarks as well as performance. There was a couple of past compensation consultants since I've been here, I know, and there's one ongoing right now by the Hay Group. And I know that that particular article in the Tribune did not include all the Health Science Center presidents, and that does. I'm somewhere right in the middle of that group.
In the middle?
Of the Health Science Center presidents, yes, ma'am.
At 904,000?
Yes.
That's the middle? Well, they'll have to follow up, won't they? The other thing is that we saw another article about the growth in administrators. For example, in 2007, you had a total of 29 persons in leadership positions, and 2 years later, although your student body grew from only 1,153 to 1,395, suddenly you had 42 people in leadership positions. And how do you justify that?
When you compare over the last several years, our FTE administrator, and that's how much time an FTE administrator serves as an administrator, we've gone from 23.50 in 2005, that'd be the year before I arrived, and 23.59 this year, which is roughly the same as far as part of the things that we did. I believe in looking at other top medical schools, top health science centers, faculty administrators should be faculty. So we have encouraged and required our faculty administrators to also be faculty. And that has reduced the overall administrative cost burden across the board. So for example, our provost is about 50% NIH funded, very key administrator. Our graduate school dean is about 60% NIH funded. I personally am an obstetrician. I still deliver babies, John Peter Smith Hospital, which is my favorite part of the week, and also teach and do writing. So we have now required all of our administrators who are faculty to also serve in the capacity of faculty. So our total head count has ranged from 28 was the year before I arrived to 32 in 2006, and now it's 30 total head count administrator. That'd be the body. So we've gone really flat as the FTE administrators, and head count, frankly, is pretty flat. That it goes together with a 90% growth in our revenues overall when you combine everything. So we really have grown pretty substantially. In fact, our administrative compensation as a percentage of total revenues has gone from 3.96% to 2.75% from 2005 to now. So we have progressively reduced. The way we've done that, we certainly have grown. We have become much more efficient in our processes to be able to support that. But we're much bigger now than we were before, and now we have roughly the same number of administrator headcount, which is the result of this reduction in that.
Thank you. Thank you, Mr. Chairman.
Senator Alside.
Thank you.